Welcome, student. I am so glad you have joined me today to learn about acute pancreatitis. Man, there is one thing that comes to my mind when I think of this condition. I think of alcoholics, I think of severe abdominal pain, and I think of death. Oh, well, okay, that's actually three things that come to my mind, but who's counting? Now, what comes to your mind when I say pancreatitis, or maybe even just pancreas? Maybe an endocrine gland, maybe insulin production. How about exocrine gland? Maybe pancreatic enzymes. All are correct. Anyway, I want to actually follow that thought about the enzymes. The pancreas secretes lipase, trypsin, elastase, and elastase. These essential digestive enzymes are going to be flowing from the common bile duct out through the sphincter of Oddi. And they actually flow into the duodenum and they break starches down, proteins, fats. They are essential to the digestive process. All right, so that's great. Now what? What would happen to the endocrine and exocrine function if those cells were obstructed, destroyed, or maybe exposed to their own enzymatic processes? No bueno. It is not known yet, but somehow activation of the pancreas digestive enzyme occurs inside the pancreas. And when that happens, all hell breaks loose in there. In a sick, cannibalistic way, the pancreas actually begins to digest itself. We call this autodigestion. We have enzyme activation, which will then lead to toxic injury to the cell, which then leads to inflammation and edema from the injury. Well, then all of this causes more pressure to the blood vessels, and then now thrombosis actually develops, followed by ischemia and increased vessel permeability. The vessels and the tissues will then begin dissolving inside a person and subsequently rupturing into the abdomen. So, what ultimately happens in acute pancreatitis is actually death. Okay, just kidding. No, but actually I'm really serious. Someone who has acute pancreatitis can develop necrotic pancreatitis, which, if not immediately treated aggressively, that can lead to massive internal hemorrhaging. It could lead to a left pleural effusion. It could even lead to a severe form of pulmonary edema called ARDS. Whenever it's not related to the heart. And ARDS stands for acute respiratory distress syndrome. And that is actually the leading reason for death for someone who develops acute pancreatitis. Let's see, some other complications. We call it DIC, or disseminated intravascular coagulation. Hypovolemic shock, actually, from the internal bleeding, or a patient can have massive vasodilation and third spacing, which, by the way, will now lead to renal failure. Oh, God. And then, last but not least, this condition can lead to paralytic ileus. No thank you. I will pass on the acute pancreatitis. Now, with early disease diagnosis and treatment, major complications can totally be avoided, as many pancreatitis cases are mild, but the more severe cases do have a very high mortality rate. So, if you ask me, why do I think of those three things whenever it comes to acute pancreatitis? Well, let's go on. I'll teach you more about it. Come on, let's do it. Let's dive right on into the etiology. The two most common reasons for this condition are biliary tract disorders, particularly obstructive gallstones, which happen to obstruct the common bile duct. So bile can't flow out. And the other one is alcohol abuse. In fact, if someone has pancreatitis due to alcohol use, their prognosis is actually pretty poor. Now, which races are more prone to this and which genders? We actually are going to find higher incidences of pancreatitis in the African American population and the male gender. However, as you will soon find out, or if you've maybe already listened to that lecture, women are actually more prone to cholelithiasis or gallstones, so don't be surprised if you see pancreatitis in a female following a biliary tract issue, because they are the ones who get gallbladder issues more often, and we know gallbladder issues can lead to pancreatitis. Now, I have a little acronym of the risk factors, and this is actually a pretty popular acronym that's going around in the medical community. And the acronym is I get smashed. Yes, I get smashed. Maybe to help you remember the alcohol, I guess. But anyway, the I stands for idiopathic. There are some cases of pancreatitis that have no identified cause, so that we call that idiopathic. Get, all right. The G stands for gallstones. E stands for alcohol. I know we use ETOH when we write alcohol. You're not crazy. We don't spell it like that normally. All right. T stands for trauma, and specifically the penetration of the pancreas can lead to pancreatitis. Okay? Smash. Now, S stands for smoking, people who smoke. M stands for mumps or malignancy, such as pancreatic cancer. A stands for autoimmune. Some conditions that are autoimmune are HIV, maybe mumps, and even lupus. The S stands for scorpion stings. I know, right? Very foreign to us in the South, but scorpion stings. H stands for hyperlipidemia and hypercalcemia, having too high of a calcium level. E stands for ERCP. This is actually a procedure, and are you ready for this? The procedure is called endoscopic retrograde cholangiopancreatography. Endoscopic retrograde cholangiopancreatography. It's called ERCP. Don't worry, we're going to learn more about that soon. D stands for drugs. Specific drugs that can lead to cases of acute pancreatitis are opioids, sulfonamides, those are some kind of antibiotic, thiazides, such as hydrochlorothiazide, and steroids, corticosteroids. Attacks are common on holidays, believe it or not, and vacations when alcohol consumption is high. Classic presentation of an acute attack includes severe, constant, knife-like pain in the left upper quadrant. It can even be to the mid-epigastric area, right between your where your ribs meet. And it could also be pain that radiates to somebody's back. They will describe this pain as boring, not boring as in, oh, boring, this is so boring, but boring as in like they feel like something's being driven into them. It does tend to lessen when sitting up or when the patient is leaning forward. These findings are related to the complications of this condition as well. Oh, sorry, let me rephrase that. The following findings are related to the complications of this condition. So what I'm about to mention may be present or may be absent. So We may possibly have crackles if a person has developed a pleural effusion. They may experience tachycardia. This can be for two reasons. They'll have tachycardia either from pain or from hypotension just before they go into a shock-like state. A patient may experience a high temperature or a fever. This is related to necrosis that is set in, which is followed by infection. A patient may experience confusion, and this is related to hypoxia if somebody's not exchanging oxygen well, such as in that acute respiratory distress syndrome. If we were to listen to their abdomen, if a person developed that paralytic ileus, we're going to have absent bowel sounds. Now, remember one of the H's and I get smashed? Right? It was hypocalcemia. So we may actually see a positive Trousseau sign on their arm and a positive Vostick sign if we tap their face. I want to show you a picture of one of the signs and symptoms that a patient is going to have. On the left here, I have colon sign. Colon sign. This is when a patient has who has pancreatitis develops internal hemorrhage, and right around their belly button, they'll get this bluish peri-umbilical discoloration. You're going to notice as well some ascites, that the patient's abdomen is very round and distended, and you're probably going to notice that the patient is jaundiced. On the right-hand side here of the slide, we have a very interesting finding called Turner sign, or we say gray Turner sign. This is where they're going to have this bluish-looking flank. Bluish-looking flank. Okay, let's go back to that other slide that we were just on. Okay, back to where we were. We're going to do a psychosocial assessment of our person really only if they have pancreatitis as a result of excessive alcohol intake. What we need to do is ask them the CAGE questionnaire. Now, please listen to this. When you ask this question, these questions, say it very nonchalantly. Stay straight-faced. Don't get surprised by their answers. If they answer, they drink 18 cans of alcohol a day, act like that's super normal to you to hear that. Like, okay, all right, and just kind of keep that person going. Do not give them any shock expression or you will shut them down. Okay, so what we're going to do is ask them the CAGE questionnaire. If you are not familiar with the CAGE questionnaire, this is a really good screening tool that lets us know, according to how they answer, that we may have a drinking problem that is out of control. Well, how do you know if they're out of control or not? Let's see. If a man answers this questionnaire 2 times with a yes, it is a good chance there is an alcoholic. If a female answers yes 1 time, there is a good chance she is an alcoholic. Well, what are those questions? Here are your CAGE questions. First one is, have you ever felt the need to cut down on your drinking? 2, have people annoyed you by criticizing your drinking? 3, have you ever felt guilty or bad about your drinking? 4, do you need an eye opener? And for those of you who are unfamiliar with the lingo here, eye opener refers to pre-noon consumption of alcohol. Like if somebody really strongly feels that it's okay to maybe drink alcohol first thing in the morning. They call that eye opener. Okay. So those are your psychosocial questions. We can ask them a little bit further and get to know about their stress levels, maybe about their activities, maybe while they're drinking, like are they just watching TV, or maybe do they have a traumatic life experience that is leading them to do these binge sessions. always, always, always make the suggestion for help if they want it. I have lots of resources. Think on it. Let me know. Here's your call bell. Oftentimes, it is probably going to be that nurse. Even though you tell that patient 20 times, it's going to be the 21st time that they actually will reach out to you. So don't give up on patients. Everybody should have a shot at getting help and having hope in their life, even though they failed 20 other times. Might be the 21st time. Okay, labs. Let's talk about labs. We will see a rise in amylase and lipase. Now, pay attention closely. An elevated lipase takes a few days to trend up, and it's a bit more reliable in someone who has acute pancreatitis. Talking about lipase, okay? Now, if they delay in getting treatment and 2 weeks goes by without any sort of treatment from a physician, then we actually won't see elevated lipase levels, because after 2 weeks, they sort of level off and trend back down and stay normal, even though a person has an acute episode still going on. Now, if we see an elevated amylase, it actually may indicate that a pseudocyst is present. You can evaluate and test for amylase in the urine as well, as a lot of times when it is getting backed up in the bloodstream, it will begin to get filtered out into the kidneys, into our urine. If we were to draw a complete blood count, we are going to see possibly elevated white blood cells. If we were to do a liver panel on our person or a hepatic panel, we're going to see an elevated total bilirubin. And this is really only indicative if there is a duct obstruction. That's whenever our total bilirubin will go up. Otherwise, it will kind of stay the same. Let's see, remember that H part and the I get smashed? Right, we're going to see a low calcium, and we're possibly going to see a low magnesium. So magnesemia. If we were to check their glucose levels, because you're that good of a nurse, you're going to notice that the sugars are actually going to be higher, right? I mean, that kind of makes sense. The pancreatic cells are temporarily not making either enough insulin, or they're not making insulin at all. Well, how high this is, let me rephrase that. Okay, so how high a person's sugar is should be correlated with their white blood cells and a test called ESR, which stands for erythrocyte sedimentation rate. Sometimes in the hospital we just say sed rate for sedimentation rate. But we're going to correlate their sugars, their white blood cells, and their ESR, and this is going to tell us how severe their disease is. Imaging assessments. Okay, so now we know the best test for gallstones. Do you know what that is? No, probably not, if you haven't listened to the gallbladder section yet. It is actually going to be an ultrasound. Particularly, we're going to do an abdominal ultrasound, trying to look for some gallstones, because those are major contributors for pancreatitis development. Now, downside is not all types of pancreatitis involve gallstones, right? So we are actually going to do a CT scan with contrast, and this is actually considered very reliable in the diagnosis of acute pancreatitis. So ultrasound, great test, because we're really looking for those gallstones. However, you know, not all types of pancreatitis involve gallstones. That's why we like to rely on the CT scan with contrast. That is the most reliable and diagnostic tool for acute pancreatitis. One of the first things we want to do is make sure to manage our patient's pain level. we're going to begin by giving them narcotics. We may even possibly get an order for a PCA, or for patient-controlled analgesia. We're going to position our patient in a side fetal position, or we actually are going to position them in a high Fowler's, like sitting up, maybe even leaning forward. The pain is going to be intense from the first couple of days, maybe even the first 2 to 3 days, but it can last all the way up to about 2 weeks during an acute attack. We're going to make sure to place our patient on oxygen. This is really just supplemental due to the risk of pleural effusion and maybe even ARDS that a patient could develop. We're going to hook them up to IV fluids, and with that being said, please make sure to assess the lung sounds and their oxygen saturation frequently, as well as even their weight. Remember, the #1 threat to a pancreatitis patient is ARDS. So get that set. Make sure there is no significant difference in a patient's I&O. This is important anytime a patient is on IV fluids. I wonder what you think is a significant difference, actually. Is it 2,000 milliliters in and 1,500 out? Is that considered significant? Well, I'm glad you asked, because usually greater than a 500 to a 900 milliliter difference is considered significant. You know, we do try to account for the water that is lost through the respiratory tract, through the skin, and even through the stool, through the bowel system. So anyway, I just thought I'd throw that in there. Let's make sure a patient gets antibiotics, especially those who have necrotizing pancreatitis. This is due to pseudocyst formation, which can lead to rupture. Make sure our patients get antiemetics or anti-nausea medicine. Antiemetics is fancy for anti-emesis or anti-nausea. So give them medicine for nausea, and make sure to give them antacids, particularly the histamine receptor antagonists, such as, oh, don't go blank. I've gone blank. Okay, let's just keep going. You can also give them PPIs, or proton pump inhibitors. The one that I'm thinking of is omeprazole, which is also known as Prilosec, or we can give them pantoprazole, which is Protonix. Make sure your person is NPO. We may even give them TPN, that total parenteral nutrition. That's basically what we say, steak and potatoes through your veins. I don't know why we say that's kind of corny, actually. All right, TPN. Anytime somebody is on total parenteral nutrition, we need to monitor their electrolytes very closely. What I mean by that is every day. A person may have an NG tube inserted with orders for gastric decompression, because we know our patient is prone to a paralytic ileus. So this means their stomach is not moving, but the patient is still going to be secreting gastric juices. We don't want them to constantly be vomiting. That's very uncomfortable, very stressful for the body. So that's why we have the NG tube down, decompressing their stomach and sucking it out into our little measuring container. Be sure to tell your CNA, your certified nursing assistant, to perform oral care and nair care, so like nose care, for anybody who has an NG tube. Food can be introduced when the pain is lessened and the person is positive for flatus, or they're passing gas. Now, what if that person, when they begin eating food, the nausea comes back, the vomiting comes back, even diarrhea that comes back? You go back to NPO status. I would call my physician, let him know that we were unable to advance the patient from NPO to a diet, and that you're going to get the order to go back to NPO. But that's significant. Let your doctor know. administer administer some vitamins to your patient. The A deck vitamins, vitamin A, vitamin D, vitamin E, and vitamin K. Do you think the A deck vitamins are fat soluble or water soluble? Fat soluble. Excellent. We need that because that's what our enzymes typically do. They break down our food that we ingest, and in absence of those enzymes, somebody's got to help us get those vitamins. We're going to administer our patient omega-3 fat oils. It is necessary to bring in a dietitian because they're going to try to calculate their calorie needs, either when they're on TPN or when they begin eating. A dietitian is essential. All right, here's that ERCP. This is a procedure that is done by putting our person into a little bit of a, I was going to say a gentle sleep. That's not the word I'm looking for. We can put our person in some conscious sedation, and we're going to take a scope going down their throat, through their stomach, into this small bowel area, and we're actually going to find the sphincter of Oddi and create a small opening. If the pancreatitis has a gallstone, we're going to remove it, and a lot of times if there's a stricture, they will put in a stent. They may even try to open it by doing a plasty on it. Whatever they need to do to open up the obstruction will be done through this procedure called an ERCP. However, warning, just the very act of going down and manipulating the sphincter of Oddi can actually worsen somebody's case or even cause a case of pancreatitis. I know, we're going down there to help it, but we can make it mad, really mad. So if you are recovering a patient from an ERCP, please make sure to monitor and report any worsening signs of pancreatitis. What else do I want to say about the diet that you can see there? Okay. Yep. I mean, you can read it yourself. There we go. Okay, here we are. We're getting to the end. What are some of the complications of acute pancreatitis and how we're going to manage it? Okay, so if we are looking at hypovolemia, this occurs because of third spacing, and maybe hypovolemia can occur because of vomiting. And if that's the case, we're going to replace their fluids and we're going to put them on antiemetic medications. Hemorrhage. To be able to monitor for this, please do CBCs every single day. Draw their blood work and look for signs and symptoms of anemia, such as paleness, tachycardia, maybe fatigue, or shortness of breath with activity. I always like to look at a patient's palms. I feel that through just the assessment of their palm of their hand, I can see if it's pale or if it has like a pink tinge to it. Even African Americans, their skin will have a pink tinge, and if you don't have a point of reference, sometimes I will turn my patient's hand over and then I'll put my hand next to it because I know I'm not anemic, and I'll be able to compare and contrast to see if they're anemic or not. It's kind of hard if you're looking at it for the first time. You'd be like, yeah, that looks normal to me, and they could be really anemic. Okay, acute kidney failure. This can be the result of hypovolemia. Make sure to monitor their BUN and creatinine, their I's and their O's, ins and outs. Okay, paralytic ileus. This one's kind of a simple one to monitor for, but listen for bowel sounds, and you can go ahead and ask that fun question, are you passing any gas? and see what they tell you. Hopefully, yes. All right. Septic shock. Let's make sure to monitor their blood pressure, usually Q1 to Q4 hours. If they are having a left lung effusion and maybe atelectasis, this is very common in older adults. Make sure they cough and deep breathe. Encourage them to splint their chest when they cough, and they need to use their incentive spirometer, maybe about 10 times an hour. Now, organ failure, this is a little hard one to monitor and to treat. However, occasionally a person will have this whole body response to the inflammation that's occurring in the pancreas, and so all of the organs will begin to fail. You will see it in all the lab work. This person is going to end up on a ventilator and dialysis, hopefully for a short period of time and not for long. Now, I mentioned DIC. This is disseminated intravascular coagulation. We need to monitor for this condition by looking at their bleeding times on their blood work. What occurs in DIC is that a patient will begin to clot, and then all of their clotting factors will then get used up. And this is kind of like a 6 to 8, maybe a 24-hour time period. So they will form clots, and then after all of the platelets have been used up and all the clotting factors, a patient will then bleed out. So you're looking at bleeding times, somebody's fibrinogen, and looking at somebody's platelet levels every day. Draw those lab levels to look for DIC. I know, you got a pretty sick cookie on your hands, don't you? And to monitor for pseudocyst, we can suspect that is occurring if we look at a CT, and if that's the case, we can drain it actually. CT guided drain placement. Last but not least, do check somebody's blood sugar, and this will just simply be covered with insulin for the time being. We don't do much more for that then. And for my pancreatitis narrating performance, judges, what are your scores? 8.9, 9.7, 9.4. Almost a perfect score for Miss Lydia Tonis. Whew. Can you imagine having this much upper body strength to pull this off? Wow. It's incredible.